Welcome to National Health Transport's Documentation Training. Your instructor today is Roy Troutman. Roy grew up in his parents' ambulance service and was an EMT for over 10 years. Roy is a certified ambulance coder who has reviewed tens of thousands of patient care reports. Take it away.
With that, we're going to go ahead and start the documentation training. The first thing that I always like to stress, we need to remember that we transport patients, not passengers. The reason I say this, sometimes the hospital, if we're doing a discharge, they look at us like we're a taxi cab. They call us, they think that we're going to come get the patient, take them back to wherever they're going, which that is what we do. But this is an ambulance. It is a medical transport. So it is our job to document why this patient needs the ambulance rather than why can they not go some other way. Another thing that I always like to mention, be very mindful of how you write your report. This is not something that just comes back and gets put into the file cabinet. We do send this documentation out to patients, attorneys, health plans, hospitals, so always be mindful of how you write your report. Another thing that you need to keep in mind, you can be called into court to testify on a patient's condition. They can call you in for up to 7 years after the date of transport. So the only thing that's going to jog your memory of that transport is your report. So this is why we like you to write a thorough narrative that explains everything that happens during that transport. And lastly, you're going to see this as a recurring theme, accuracy and clear documentation. Of course, we want everything in the report to be accurate to the patient condition at the time of transport. And we want it to be clear enough that anybody who reads that report and looks it over is able to understand what is going on with that patient during the transport. The best way to think of, is my narrative clear enough? We need to be able to picture everything that happens from the time you come into contact with that patient till the time you drop them off.
Remember, your PCR is a legal document. Write it so you can remember what you wrote.
Going to do a quick overview of what the QA process is. The first thing that happens, of course, you run the call and you complete your report. After you complete it, QA reviews it. They look for errors. They look for errors such as not having your 2 sets of vitals. They check your signatures to make sure they're proper. If it's a non-emergency transport, they look for a PCS form. They also do other things like they compare the locations that you have listed on your report to the CAD system. They want to make sure that those two go together. Once they're done their review, they send the report over to billing. When it goes to billing, that is where they pull all the verifications for insurance and different things like that. That is also where the report gets entered into the billing system. Once it gets entered into the billing system, it gets sent to Tina and myself, who code the call. As we're reviewing your report, we check for medical necessity to make sure it was necessary this patient went by ambulance. And we either bill out the call, or if we have any questions, we send it back for an addendum. You'll hear these called M&Rs, which means it's a medical necessity review. There's 2 ways that we send these back to you. If it's an electronic report, I send it back in ESO. When you log in that day, you'll get a alert that you have a QA message. What you do is you click that message, it'll show my question, and it'll have a hyperlink that you can click, and it'll take you to the report where you can make an addendum. Once you complete the addendum, send me a message back through ESO stating that it's done. That way it'll trigger on my end that I have an addendum that needs to be worked. The other way that we can send it back to you is if it's a paper claim, I will send an email to QA. They will write up a paper form and they will make sure that it gets to you so you can fill it out and they can send it back to me. Once you reply to the addendum request, I review it, and then hopefully I'm able to process the claim further.
In emergency medical services, acronyms are very prevalent. Familiarize yourself with the acronyms on the board as they will be used throughout your career.
A lot of the crew members think that QA is pestering them. Nobody wants to be questioned. Basically, what we're trying to do is we're trying to make sure that we have the correct details and it's clear enough that anybody who looks at the report can understand it. A lot of our health plans, including Medicare, actually employ RNs to review the ambulance run sheet. And as we know, RNs don't always understand fully what happens in the back of an ambulance. So we need it to be very clear. Also, we're trying to make sure that we have that complete and thorough picture of our patient condition. We need to know what this patient can and cannot do, why they require the ambulance for transport. And lastly, if you ever have any question or don't understand why we're asking something, let somebody know. We would much rather you understand why we're asking a question or what we're looking for than not understand. Also, this helps so things don't become a repeat issue. We don't have to keep asking the same question over and over again.
Remember to paint a clear picture with your words. Make sure that other people can understand what was going on your call by reading your patient care report.
We're going to go into the emergency transports. This is a pretty quick section due to the fact that usually emergencies have a clear-cut chief complaint. We know why they're going to the emergency room. Now, a question that I have for you guys, is every call that comes in for an immediate response an emergency?
No.
No. Here we have an example. We arrive on location at an assisted living. The patient was sitting on the curb on arrival, complaining of left big toe pain 2 out of 10. The patient stubbed their toe on a chair while walking. The patient stood up, walked over to the cot. Vitals were assessed en route. On arrival to the ER, you lower the cot. The patient stands up and walks over to the bed. Care was passed to the nurse on duty. This is not an emergency transport. This patient could have gone some other way. So, what we ask that you do if you come into a situation like this, call into dispatch. They're going to put you over to QA. QA is going to ask a few questions to see if there's something that may be missed. Do they have any bleeding? Is there any deformity of the toe? They're basically just going to jog your memory to see if there's something maybe that's being overlooked. We're not going to deny the transport. We're still going to take the patient to the emergency room. We're going to ask that you document your narrative as you would with any other patient, but write a sentence at the bottom of that narrative saying that you called into dispatch and spoke to QA. That way, when I look at that call, I know that you went through the process of how the chain of command and that QA did their questioning. What I would end up doing with this call most likely is this would end up getting billed to the patient because they probably could have gone some other way. They were ambulatory. They have a low acuity of pain. So, what is it that we look for on a claim to determine does this patient need to go by ambulance? The first thing that we look for is medical reasonableness. The name kind of explains what it is. Is it medically reasonable? So, some ways that we can meet medical reasonableness. Does this patient require the ambulance for the transport? Basically, why are they unable to go some other way? Some ways that this can be met. They could require monitoring. It could be oxygen monitoring. Say you have a shortness of breath patient who's never been on O2. They wouldn't know how to administer their own oxygen. It could be mental monitoring. If the patient has confusion, some type of lack of awareness, they could be a danger to themselves if they were left alone. They could be a fall risk. If they were to be left on their own, they could possibly injure themselves. They could be unable to go by other means due to a mobility issue. These would be our patients who are non-ambulatory, unable to safely sit in a wheelchair. Or medical reasonableness could be met because they require isolation due to an infectious disease. This could be our COVID patients, patients who have E. coli or C. diff. any of those diseases that you wouldn't want somebody else to catch had they gone some other way. The best way to think of is this reasonable is you put yourself in that patient's shoes. How would you get yourself to the emergency room if you were in that situation? Now, the one thing you have to remember, you have to take it from the layperson point of view, not the medical point of view that you know. So look at it from their point of view. Would you find it reasonable to call an ambulance for this transport? Now, the next thing that we look at is medical necessity. Again, the name kind of explains it. Is it necessary that they go by ambulance? Medical necessity can be met by any life-threatening injury or problem. Again, you're looking at it from the patient's point of view. Medical necessity can also be met due to needing some type of intervention that they normally would not have access to. Again, your shortness of breath patient, they need O2. If they don't have it at home, that is an intervention that they would need. Medicine, splinting, bandaging, basically any type of care you're going to provide for that patient in the ambulance that they wouldn't have access to if you were not there with them. Or lastly, medical necessity can be met if the patient is a danger to themselves or others. This would be our psychiatric patients. As I said, emergency transports are pretty clear cut. Usually we have that chief complaint. We know why they're going in. A few last things I want to mention for the emergency portion. Always remember to document your interventions. This is your O2, your splinting, bandaging, backboards. Are any of you guys medics?
Yes.
Okay. If you do cardiac monitoring, always remember to tell us what the outcome of it is. Is it normal sinus rhythm, AFib, whatever you see on that strip, we need to have it documented on the report. The next thing, give us all the details that you can. The example that I use for this, say you go into the nursing home, they tell you the patient has a UTI. If that's all you put in the report, I'm going to have a few questions for you. The first thing is, how do they know it's a UTI? Is it lab confirmed? The next thing, what are the signs and symptoms? A lot of the signs and symptoms of a UTI are kind of general symptoms. The altered mental status, the lower back pain, those types of things. Why do they know that it's a UTI, or do they just think it's a UTI? Also, the signs and symptoms are very important, so we need to know what is going on with that patient. The next thing I like to mention, OPQRST. This can be used for almost any complaint or issue. It gives us all those details that we look for. And then lastly, we always want to document any improvement our patient shows. So if we put them on oxygen and their O2 sat rises, make sure that's documented. If they're in pain and you position them in a certain way, document how you position them and what the outcome of that is. Did it help or did it not help?
Remember, all transports that go to an emergency room are not true emergencies. If you believe your trip is unreasonable, contact the QA office. But remember, each time you speak with them, to document it in your PCR. And if you haven't done so already, familiarize yourself with the mnemonic OPQRST. It'll help you to document your patient's condition in the event of an acute illness.
Now we're going to go to the non-emergency transports. These get a little more tricky. Non-emergency transports need to meet medical necessity and reasonability standards as well. We just have different ways of meeting them. We don't have that clear-cut chief complaint like we do for emergencies. Again, we need a clear and precise documentation. And a few things that we always look for on our non-emergency transports. These transports are going to be coming out of the hospital. So the first thing that we're looking for is, why were they there? Why were they in the hospital? Another really good thing to document, if you're able to find it out, how long were they in the hospital? The next thing we need to know, Why do they require the ambulance? Why are they unable to go some other way? And then lastly, what was done for the patient during the transport? So did you give them oxygen? Document about taking their vitals. Any positioning you may do for them. Anything you do for that patient, you want to have it documented. We're going to go over mobility. This is the first thing that we look at when we have a non-emergency transport. We want to know what that patient can and cannot do, and a lot of times that determines why they're unable to go some other way. The first thing we're going to go over here, bed confined versus bed bound. A lot of people think these two words mean the same thing, but they actually have different definitions. A bed confined patient is someone who is unable to ambulate with assistance of another person or by themselves, so they're non-ambulatory by any means. They're unable to get themselves from the bed without assistance, and they're unable to safely sit in a wheelchair and support themselves for transport. Now, we're not saying this patient can't sit in a wheelchair in their room. We need to think of it from the transport point of view. So, can this patient sit in a wheelchair in the back of a wheelchair van safely and not injure themselves if they were to transport that way? Now, bed bound. This is a patient who their doctor has ordered bed rest, but they can get up from the bed if they choose to do so. These are the patients that we see they might use a potty chair beside the bed. So they stand up, pivot, they can sit on it. They might get up and get into a recliner beside their bed. Or they might just be ordered bed rest, but they can get up and fully move around if they want to. Knowing the difference between these two makes a big difference. So, what is it that we ask that you document in your narratives about mobility? We ask that you answer 3 questions, and we ask that you document this in every single narrative that you do. The questions are, can the patient ambulate with or without assistance? Can the patient get themselves from the bed without assistance? And can the patient safely sit in a wheelchair and support themselves for the transport? These are kind of familiar because these are the 3 questions that we ask if the patient is bed confined. If you answer all 3 of the above questions, I'm able to clearly determine this patient's mobility, and that helps me properly bill the transport. The next thing we're going to cover is oxygen. If a patient is on oxygen, there's a few things that need to be documented. The first one's pretty simple. How much and what route was it given to them? This is as simple as saying they were on 2 liters per minute nasal cannula. Now, one thing that I do like to mention at this point, had a crew member one time documented that the patient was on 15 liters by nasal cannula. As we know, that's a lot of oxygen for a nasal cannula. So I questioned the crew member, just wanted to make sure. They come back and the only explanation they gave me was 15 liters nasal cannula. I reviewed the addendum and I thought, that's a lot of O2. I just want to make sure. So I got more in depth in my question. I said, hey, this is a lot of O2. Just want to make sure nasal cannula was the correct route it was given. The crew member come back and stated this patient had an end-stage respiratory issue. This was the actual amount and route that they normally are on per their doctor. So had the crew mentioned that in the beginning, I never would have questioned it. So that's another thing to keep in mind. If there is something that is out of the norm, document why it's that way, just to save yourself from being questioned on it. Now, a few other things we need to know if a patient's on oxygen. We need to know, does this patient have access to their own portable O2 tank? And do they have the knowledge to be able to self-administer their O2? The reason we need to know this, sometimes oxygen is the medical necessity that requires the ambulance transport. So you might have a patient who is fully ambulatory. They could possibly sit in a wheelchair to go some other way. But if they don't have their own portable O2 tank, or if they don't know how to self-administer that O2, then they would require ambulance transport for their oxygen administration. And then lastly, we do ask that you document when you place a patient on O2 at the receiving facility, and we ask you to document what type they're placed on. If they're in a nursing home, you might plug it into the wall, or they may use a concentrator, like the floor model plug-in. Whatever you put them on, just document it at the end of your narrative what they were placed on.
Remember with oxygen the importance of noting volume and delivery method. Also document things that may cause QA to question, like high flow through a nasal cannula.
We're going to go over COVID documentation, and as you'll see, this section is starting to get dated. We've been dealing with COVID for a long time. This was made when COVID was fresh. Proper documentation of a COVID claim needs to include a few things. The first thing that we need you to document, the PPE that you use. So it's as simple as stating that you wore goggles, gloves, gown, N95, whatever it is that you wear, we need to have it documented in our narrative. I do know that there's a section under the personnel tab where you mark the PPE. For some reason, that does not actually come over on the report that we print out when we bill the claim. The next thing that we need to know is, did you provide isolation for this patient, either due to being COVID positive or possible COVID and exposure? We want to make sure that we isolate these patients so we're not spreading the disease. The next thing, any signs or symptoms the patient is having, or are they asymptomatic? Sometimes we will have these patients be COVID positive, but they have no signs or symptoms. The next thing, any irregularities of their vitals. Do they have a fever? What's their O2 sat? What's their lung sounds? Anything that would be abnormal, we want to make sure we have that documented. And then lastly, we want to know, have these patients been tested? Are they COVID positive or negative, or do they require to be tested? We did come up with a way to try to make this a little easier. Think of the word COVID. C is your covering. What PPE did you use? O is your observations. What signs and symptoms is this patient showing? V is your vitals. Do they have a fever? What's their O2 sat? What's their lung sounds? I is your isolation. As I said, we want to make sure we isolate these patients so we're not spreading the disease. And D is our diagnosis. Are they positive or negative? Do they require to be tested?
Don't forget to document any personal protective equipment that either you or your patient wore during the ambulance transport.
Okay, here is a section where we go over some sample narratives. I want you to look at these narratives from the QA point of view. So you're going to be questioning anything that just kind of sticks out to you, doesn't make sense, or something that you see as wrong. Now, before we start this, I am going to mention these are sample narratives, so I didn't get very in-depth with patient demographic information, and I didn't get real in-depth with vitals unless they were something that we were going to be looking at. Some of them I say, vitals were assessed. Just take that as everything was normal. Some I do say were within normal limits. As for the demographics, usually we would expect a narrative to start out saying, you arrive at this location, this is what you found, this is where you're taking the patient to. But like I said, with the sake of these being samples, I was very vague in that type of information. So here we have example number 1. Unit arrives on location at a hospital to transport a patient back to their residence. The patient is status post and admit due to weakness. The patient was found standing at the window. Patient assisted to the cot. O2 was transferred to the unit portable. In the unit, the patient O2 was transferred over to the main tank and vitals were checked. Patient states no pain or problems currently. They do show some global weakness. The patient requires ambulance transport due to bed confined, global weakness, and O2 requirement. On arrival at home, the patient was assisted from the cot to the recliner chair. Patient O2 was discontinued as the patient does not have home O2. Patient was left in care of self. What are some things you would question about this narrative?
They didn't, when they were talking about the oxygen, the BLS transport, they didn't state if they have a portable or have their own use at home or if they were on oxygen before the
Yep.
hospital.
It says patient found standing at window, but then says bed confined.
Yes, definitely would want to question their mobility. What's going on there?
They didn't really explain why they're not mobile.
Yeah, the mobility definitely we have questions on. We want to know what's going on here. How can they be standing at the window if they're bed confined? Okay, you guys got it. So, on the left-hand side here is how I these are actual questions that I would send to you if you were the crew member that wrote this narrative. On the right-hand side are examples of answers that we would expect to see. Now, the one thing I have to mention, please do not take this as me telling you if I ask you this question, this is the exact answer I expect to see. Of course, we want every answer that you give us to be truthful, and we want it to go with the patient. Not every patient has the same exact answer. These are just examples. O2, how much and what route? No O2 at home. Why was it required for transport? I would state patient bed confined but found standing at the window. Now I need a full mobility. Can this patient ambulate? Can they get themselves from the bed? And can they safely sit in the wheelchair for transport? Lastly, something else I would question. This patient was left in care of themselves. How do they function in their home? So, some answers we would expect to see. O2 at 2 liters per minute nasal cannula during the hospital stay, but it's not required at home. This is something that we do see fairly often. A patient may be on oxygen during their hospital stay, but they may not use O2 at home. So right there we know oxygen does not meet our medical necessity. So oxygen was not the requirement for them needing to go by ambulance. So for the mobility, this patient is not bed confined. They're ambulatory for a short distance. They can get themselves from the bed, but they're unable to safely sit and support themselves in a wheelchair for transport due to weakness and fatigue. The nice thing about this answer, it tells me what the patient can and cannot do, and it tells me why they can't do it. Our medical necessity would be met here because this patient is unable to safely sit in that wheelchair for transport due to their weakness and fatigue. Lastly, although this patient was left in care of themselves, the patient family was to arrive shortly and does live with the patient and monitors them. I answered this very specifically. Normally, we don't want to leave patients by themselves, but we do live in the real world. If you are ever to arrive on scene and the patient is to be left in care of themselves, what you need to do is basically follow your gut instinct. Is this patient going to be able to self-sustain themselves until somebody is able to arrive there? If you're uncomfortable leaving the patient in the condition that they're in, call dispatch. They will advise you how to process with the rest of the transport. Another thing I always like to mention, if you leave a patient at home or in the nursing home, anywhere you leave them, if they have a cell phone within reach, if they have a life alert, if they have a call button, make sure that that patient has it within their reach and document in your narrative that they were left with that device. That shows that you left that patient with any type of thing they may need if they are to have some type of issue. Example number 2 that we have here. We arrive on location at an assisted living to transport to the ER. Patients found laying in bed complaining of a productive cough and a fever. The nurse states that the patient roommate had the same symptoms and tested positive for COVID yesterday. Patient seems confused on speaking. Their ANO times 1 with a GCS of 15. Patient moved to the cot by the 2-person draw sheet. In the vitals, units were assessed. O2 sat shows low. Placed on O2 at 2 liters per minute. On arrival to the ER, the patient was moved from the cot to the ER bed. Patient care to the nurse on duty. What are some issues we see here?
The GCS doesn't make sense because it says
No.
ANO times 1.
Yep. That's something that we actually see a lot, and a lot of times it's just a typo, but it's definitely something we would want to question.
With
What else?
O2 stat shows low placed on O2 at 2 liters per minute doesn't make sense to me.
Yes. We would need to know what was the actual O2 sat and what route was the O2 given.
Since she tested positive, or the patient tested positive for COVID, there's no PPE that was stated that was worn, or isolation measures.
Yep. We don't have our PPE. We don't have our isolation documented. Actually, the patient roommate had tested positive, so we need to know, was the patient tested? Lastly, let's look at our chief complaint, our productive cough and our fever. How could we be more descriptive of both of those?
You can get a temperature.
Yep.
There's no sounds. Yeah, lung sounds.
Yep. And for a productive cough, what does it look like? What's, yes, if it's productive, what actually does it look like? So the questions I would ask for this one: details of the productive cough. How does it look? Fever. What is our temperature? Did we take COVID precaution due to the exposure from the roommate? What was our PPE? Did we provide isolation? We would question the ANO times 1, but the GCS of 15. Low O2 sat. What was the actual sat? O2 at 2 liters per minute. What route? And then lastly, this narrative had no mobility listed. So we would question, what is this patient's mobility? So, per the nurse, the patient was coughing up greenish yellow phlegm. Fever was 100.5 on arrival. One thing I want to mention with fevers, sometimes by the time you arrive on scene, that patient may not have a fever anymore. Say they're given Tylenol, something to bring down that temperature. It is totally acceptable to document prior to arrival, this is what the nurse states that the temperature was. The patient was given Tylenol. This is what the temperature is on arrival. Now, due to the COVID, this patient was treated as a COVID possible due to their exposure from the roommate. Full PPE and isolation was provided. The crew wore gloves, N95 mask, and gowns. The unit was deconned after transport. If you're going to take the time to decon a unit, document in a sentence at the bottom of your narrative that was done. Not only does that show that you provided good isolation for the patient you have, that shows that you're setting up that unit to be safe for your next patient. They came back and corrected the GCS. They say this patient was ANO times 1 with a GCS of 14. They were confused. They come back and correct about the O2. The O2 sat was 88 on arrival. Placed them on O2 at 2 liters per minute nasal cannula. O2 sat rose to 96. And then for this mobility, this patient is non-ambulatory, unable to get themselves from the bed, unable to safely sit in a wheelchair for transport due to their confusion. Last example that we have for this section. Unit arrived on location to the hospital for a transport back to the nursing home. Patient is status post shortness of breath and chest pain admit. Patient ANO times 4, GCS of 15, laying in bed. No complaints of shortness of breath or chest pain at this time. Patient found on O2 at 4 liters per minute, nasal cannula. Patient moved to the cot by 2-person draw sheet. Placed on unit portable O2. This patient's bed confined due to severe muscle weakness and function decline. Patients non-ambulatory, unable to get self from bed, and unable to safely sit in a wheelchair for transport. Patient placed on unit main O2 supply and vitals were checked en route. All were within normal limits. On arrival to the nursing home, patient placed on unit portable O2 and transported into their room. Patient was draw sheeted to the bed. Patient O2 was changed over to the facility supply. Patient care and report were given to the RN on duty. Do you see any issues with this narrative?
Right now, no.
This one looks good.
Yeah, for the sake of it being a sample narrative, this one actually has no issues. It tells us everything that we need. Our medical necessity is met not only by the patient requiring oxygen, but they're bed confined. It tells us why they're bed confined. They have the severe muscle weakness, function decline. They're unable to ambulate, unable to safely sit in a wheelchair. So for a sample, this one's pretty good. So QA's happy because we don't have to send out an addendum. You're happy because you don't get that alert when you log in the morning that you have something that needs answered. I took the time to put this one in so, one, you could see a sample narrative that is pretty good. It gives us all the information that we need. Two, I take the time at this point to mention, if you ever receive an addendum request and it doesn't make sense, say we send you an addendum request and we're asking for mobility on a patient and you clearly have it documented in your narrative. Send me a message back and say, hey, please review the narrative. This is documented. There's a good chance that I accidentally typed the wrong number. I mixed numbers up or something, and I sent the question to the wrong crew member. Sometimes you as a crew member forget that me as QA, I'm human as well. I make mistakes. Things do happen. Another thing I always like to mention at this point, please never take us asking a question on your narrative as a hit against you. Sometimes crew members get very upset when we question their narratives. Basically, all we're trying to do is make sure that we have clear information and it's correct. If you look at the way the report is laid out, the narrative is on about the third page of the report. Your names as the crew member are on the last page. I already have all my questions together before I even know who wrote the narrative. So it's never us coming against you as a crew member. It's just us trying to make sure that we have the correct information. And then again, as I had mentioned before, if you ever don't understand why we're asking something, or you need some type of clarification, let somebody know. We would much rather you understand why we're looking for something or why we're asking, so it doesn't become a continual issue.
Remember, the quality assurance team is just trying to understand what you've seen in front of your patient. If you don't understand the question they're asking, please feel free to give them a call. They'll be happy to help.
Okay, we're going to go over a few more points here. Inter-facility transports. An inter-facility transport is going to be any transport from one hospital to another for a higher level of care. Now, the first thing that I have to mention about inter-facilities. Usually inter-facilities are for psychiatric care, pediatric care, cardiac, burn unit. Something very major that they need a higher level of care than they can receive at the facility they're at.
Some patients require the need to rehabilitate in a hospital setting. While not a higher level of care, these rehab hospitals, also known as long-term acute care hospitals, or LTAC for short, provide a more intensive 24-hour nursing care and daily physician visits. A typical stay in an LTAC can be 25 days. Remember, the goal of an LTAC is to work towards improvement over the long term. The level of care typically found in an LTAC cannot be found in a nursing home setting.
As I said, most of these are going to be for some type of higher level of care. So we need to know what is at the receiving facility that the sending does not have. Usually it's some type of specialized care. It could be psychiatric, pediatrics, labor and delivery, cardiac. The other thing we need to know, anything that was done for the patient at the sending or during the transport. So what we're focusing on here is, were they given any type of medicines? Say the patient has abdominal pain and they're going for a surgical consult for appendicitis. Does the patient still have abdominal pain? Was the patient given some type of meds to lower that pain scale? Are you administering any meds during the transport? Also, we want to know any interventions you do during the transport. So this is where our cardiac monitoring, things like that, we want to have them documented. We're going to go over orthopedic. The first thing we need to know for orthopedic calls, where is the injury or problem, which extremity, and which side. It is amazing the amount of claims I get that state, patient has a hip fracture. Well, if you don't tell me which side, I have a 50-50 shot there. The next thing we need to know, is there any pain? A lot of times there is pain associated with hip fractures, hip replacements, things like that. And then lastly, we want to know any devices or bandages that patient has. So if their status post a hip replacement, do they have an abductor pillow between their legs? Do they have any type of orthopedic boots? Are they in a C-collar, back brace? If their status post some type of replacement or some type of surgical repair, where is the bandage located? Telling me that there's a bandage on the patient not only confirms the side and the extremity of where the fracture or the replacement was, but, it gives me that extra clarification, just the continuity. Sometimes I will have narratives that the chief complaint on the first page say it's a right hip fracture. As I go down through the assessment, they tell me it's a left hip fracture. And then I get to the narrative and they don't tell me which side it is, they just tell me it's a fracture. Having that documentation of where the bandage is just shows the continuity. It makes sure that we actually check to make sure we're documenting the correct injury. We're going to go over psychiatric transports. The narrative must include a good description of the signs and symptoms. Just telling us a patient is a psych or that they're AMS really doesn't tell us a lot. We need to know, how was the patient acting? What is the behavior or issues the patient is having? And we need to remember that even if the patient appears fine at the time of transport, how were they acting prior to the transport to make this transport necessary? The example that I use for this, say you have a patient coming out of the emergency room to go to a higher level of care for psychiatric treatment. By the time you arrive on scene, that patient may not be in their active psychosis. They might be ANO times 4, GCS of 15. They might be calm and collected, no problem at all. Well, that's fine. We, of course, want you to document what you find on scene and how the patient is at that time. But what I need to know also is what was going on with this patient prior to your arrival that makes them a psychiatric patient, and why do they require that monitoring? Was the patient a danger to themselves? Did they have suicidal ideations? Were they in a fight with their family? We need you to document what was going on with that patient that warrants the transport. The next thing we need to know, was the patient given any type of medicine? Was the patient sedated? Up here where I'm from, our closest psychiatric facility is about 75 miles away from our hospital. It was very common for me to have patients who were sedated. Well, the first thing I want to know is, what were they sedated with, and how long do they expect this sedation to last? The last thing you want is to be in the back of an ambulance with a patient who's coming out of sedation, and they decide they don't want to be in that ambulance with you. So it's always good to know, what were they given, how long do they expect it to last? And then lastly, is the patient a problem during transport? Are they uncooperative, trying to get off the cot, threatening? anything that happens during that transport, you want to have it documented. We're going to go over wound care. Wound care is a treatment for patients who have wounds that need to be treated. Usually these patients are transported up to 3 times a week. They go in, they get the wound treated, cleaned, debrided, and then we transport them back to their home or their nursing home. So what we need to know on these claims, we need to know, of course, where is the wound and is there multiple wounds? A lot of times these patients are dressed to go out to an appointment. So, it's hard to do a full assessment on them. It's totally acceptable to ask the patient, the family, or the caregivers, where is the wound? Is there multiple wounds that are going to be treated? Also, if you're able to find out, what is the stage of the wounds? Now, we don't expect you to learn all the stages of the wounds, but this is something that you can ask the caregivers, the patient themselves, or if you have to, ask the wound care staff. Wound care is usually very forthcoming with information with us because they understand how important it is to get these patients treated. I also mentioned mobility with this. We need a good description of what this patient can and cannot do. The reason I bring up mobility kind of as a talking point under wound care is there were some bad ambulance companies who were transporting patients to their wound care appointments, and they really didn't meet medical necessity. Medicare actually sent out auditors to prove this, and what they found was there was ambulance companies who were going and picking up patients. The patient would actually walk out of their house and sit in the passenger seat of the ambulance to go to these appointments. So we need a good description of what this patient can and cannot do. We need to make sure that they actually meet medical necessity and they can't go some other way. Another thing that I have to mention with patient mobility under these, you get to know these patients. You take them 3 times a week to these appointments to and from. So if you ever see some type of change in this patient's mobility, let somebody in the office know, because we do have people that can go out and do assessments on them, and maybe something has happened. Maybe they've gotten stronger, or they might be able to go some other way. So we might actually stop transporting that patient if their mobility changes. Okay, we got a couple more examples here. We arrive on location to the ER for a transfer to another hospital. Per the staff, the patient is AMS and requires a psych eval. Patient has not been taking their meds and they're acting out. Upon patient contact, the patient's ANO times 4, GCS of 15. Patient stood with assistance and sat on the cot. During the transport, the patient refused vitals. Patient is calm and cooperative during transport. On arrival to the hospital, patient was draw sheeted to the bed and left in care of the nursing staff. What are some questions we would have with this one?
What other hospitals are you taking to? Does it specify if it's psych or not?
Yes, why are they transferring facilities? What else would we want to know?
Help with assistance and then draw sheeted? That doesn't really make sense.
That's actually something that hardly ever gets questioned when I do this one. And it's actually not something I have listed. But it is something that is questionable. Why is this patient who is ambulatory with assistance being draw sheeted? And the simple answer to it is a lot of times it's just easier to draw sheet a patient than to have them get up. But that's actually not something I would question, really, unless it were a main factor on the transport. Let's look at our chief complaint.
I was
Did
gonna
they
say,
Go ahead.
I was gonna say, what if he hasn't been taking his medications and he's not acting right? Then why
Yep.
would we feel safe transporting him without our own assistance or with restraints too?
Well, we would want to know what meds had he not been taking and how had he been acting out. A lot of times our psych patients actually aren't restrained, But that is a good question. A lot of time the psych patients aren't restrained. Let's actually go over and see what we got here. We would want to know, why are they transferring facilities? What care is not available? Even though they tell us they need a psych eval, we need to make sure that the psych eval couldn't have been done at the facility they were at. We would ask about the altered mental status. How was the patient acting? The patient actually shows ANO times 4 with a GCS of 15. For the meds, we would ask, not taking their meds for how long? What meds had they not been taking? And then lastly, I just put this in for a talking point about the patient refusing their vitals. So we'll talk about that when I get there. So what we would need to know is, this patient was transferring facilities due to no psychiatric care available at the facility. This is something we see pretty common. The patient may be at an emergency room that the hospital does not have psych capabilities. Other reasons that we see are, maybe they have a psych unit, but it might be at capacity. They may not have room for that patient. Another thing that we see is, if it's a psychiatric or an elderly patient, they may require some type of specialized psychiatric care that they would be better suited at a different facility. Now, to describe the AMS, this patient was AMS due to agitation at their residence. The patient was in an altercation with their family and they were combative. The patient was calm during the transport and showed ANO times 4 GCS of 15 during the trip. Now, for the meds, this patient had not been taking their meds for 3 days per the family. As you see, this one does not actually answer both of the questions that I asked. What I had asked is, not taking their meds for how long, which they did answer, and then what meds. That was not answered. I answered this specifically just to bring up the talking point. Only tell me information that you are 100% certain. If you do not know something, just simply tell me, hey, I don't recall this information, I was never told this information, whatever it may be. If it is something that is drastic that I need to know, I do have other ways that I can get information. I can send to the hospital for notes. I can, get notes from the facility they went to or came from. Please never answer a question just for the fact that I asked you the question. If you cannot stand behind that answer 100%, tell me that you're unsure of it or you don't know. Lastly, about the patient refusing vitals, patients are able to request that you not take vitals. Never take that as a sign of a psych issue or something like that. It might just be a patient preference. They might not want to be messed with. Now, in the sake of vitals, I have a few things that I have to mention to you. We do review vitals. So, if we start to see that every patient you take refuses to have their vitals taken, we might start to think that you just don't like to take vitals. Also, if I start to notice every patient you take, their blood pressure is 120/80, and then the next one is 118/78, might start to think that you're not actually taking vitals. So just be mindful of that. Take your vitals like you're supposed to. I know it's a pain. I worked out on the road for a long time. I understand. Nobody likes to take vitals. But it is something that we have to do. It is a requirement that we have. Okay, example number 5 here. We arrive on location of a residence to transport a patient to wound care. The patient was found laying in the hospital bed in the living room. Patient is nonverbal. Their ANO times 0 GCS 11. Please don't kill me for that GCS. I know it's not correct. I just haven't changed it. Just take it as this patient is altered. Patient's bed confined. They're non-ambulatory. They're unable to get from the bed. They're unable to safely sit in a wheelchair for transport. Patient has a Foley catheter. They have contractures and a wound vac. Patient moved to the cot by draw sheet and placed in unit. Vitals were taken en route. On arrival to wound care, the patient was moved to the bed by draw sheet and left in care of the staff on duty. Now, before we start with what we see as issues, do you guys know what contractures are?
I do not.
Okay. Contractures are when a patient has either one extremity, it can be multiple extremities, or it can be all their extremities. You see contractures on a lot of stroke patients or patients who are just terminally ill and their muscles have contracted. This is when an extremity or all their extremities basically has pulled into itself, and that extremity has basically pulled in towards the abdomen. I don't know how to better explain it than that. Does that make sense? Do you understand what it is?
Atrophy.
Yes, atrophy. Like I said, a lot of stroke patients show it, and a lot of patients who are just terminally ill or have been non-mobile show it. A wound vac is basically it's basically a suction device that is put over a wound, and what it does is it clears the wound of any type of fluid and, secretions. We see it on a lot of our wound care patients because the drier that wound is, the healthier that wound can be. The reason I bring up those two things is those are two things that get questioned in this narrative, and sometimes, as brand new EMTs or medics just coming out of school, those might be terms that you're not really familiar with. So what are some things that we would question about this narrative?
He didn't really explain why he kind of says why he's bed confined, but in a way he doesn't really go into depth of it either. He doesn't show where the Foley catheter is or what extremities are actually contracting.
Yep.
And he basically didn't explain any of the medical necessities into details.
No, this narrative is lacking detail. That's the biggest thing. So let's see what we got here. We would want to know where are our contractures, and we of course need to know where are our wounds that are being treated. What stage are they, and where was the wound vac connected to the patient? So this patient actually showed contractures of the bilateral upper and lower extremities, and with documenting that would support why the patient is bed confined. All of their extremities are contracted. Next, this patient had a stage 3 sacral wound with a wound vac attached and a stage 2 right heel wound with a cushioned boot in place. That right there tells us why this patient is transporting and why they need to go by ambulance with those contractures. Okay, here we have our last one. We arrived to the hospital for a transport home. Patient status post a knee replacement. Patient is non-ambulatory due to pain and orthopedic device. Patient's ANO times 2 with a GCS of 15. Patient moved to the cot and vitals were assessed en route. On arrival to the home, the patient stood with walker and placed themselves on the couch. Patient care to self. What are some things we would question here?
AO times 2, GCS 15.
Definitely, we would want to question that.
It says patient moved the cot, it doesn't say how.
They said he was
Yep.
non-ambulatory.
Non-ambulatory. How is he gonna move?
Yeah.
They didn't give an OPQRST for the pain, or
Nope.
did it describe any of the pain, or what orthopedic device does he have?
Very good. We got one more thing I would definitely question.
Leaving him by himself if he's non-ambulatory.
Yep. Actually, there's one more. Let's look at our chief complaint. Why were they in the hospital?
For a knee replacement.
What's the main thing I need to know on that?
How long was he at the hospital for?
Which side of the knee was on?
Which knee?
Which knee?
Yep, definitely need to know which knee. So, what we would ask here, knee replace, which knee? Pain, what's our OPQRST? What was the orthopedic device? The ANO times 2, but the GCS of 15. We would ask about the mobility. They stood with a walker. Can the patient safely sit in a wheelchair for transport? And this patient was left in care of self. How do they function in their home? So this patient had a replacement of the right knee. Patient showed pain 5 out of 10 since their surgery. The pain is worse on movement. This patient has a knee brace in place that keeps the knee straight. They came back and they corrected the GCS, ANO times 2, GCS of 14. Now, this mobility is a little bit of a different one. This patient can stand with a walker, but they're unable to fully ambulate at this time. They require further physical therapy. So what I would see in my head for that description is this is a patient who they might be able to stand up with the walker. They might be able to shuffle their feet, to move from the bed to a chair, something like that. But they're not fully ambulatory. The patient is unable to fully bend their knee, so they're unable to safely sit in a wheelchair for transport. And that's where, knowing what that orthopedic device is, they have that knee brace on that keeps their knee straight. So they wouldn't be able to bend it enough to sit in that wheelchair for transport. And then lastly, this patient actually lives with their family and was left with family. Okay, does anybody have any questions up to this point? We have covered everything on the documentation portion.
No.
No
No
questions.
questions? Okay. We're going to go over a PCS. A PCS is a physician certification statement. PCSs need to be obtained on all of our non-emergency and our interfacility transports. The best way to think of this, if you're taking a patient out of the hospital for any reason, you need one of these in your hand. The PCS, Section 1 is the top portion. This is the only section you as a crew member are allowed to fill out. So what we need here, we need the patient's name, their date of birth. It says Medicare number, but basically we need a Medicare number or some type of insurance number. We basically need something that we can use to verify that this goes back to that patient. We need the transport date to be written in. We need the origin location, and we need the destination. Anything below the locations, only fill out if you 100% know the answer to it. So the first question about Medicare Part A, yes or no? Most likely you are never going to know the answer to that question if the patient is covered under Medicare Part A. So if you don't know that answer, leave it blank. The next thing, is the patient going to the closest appropriate facility? Yes or no? The only time the patient would not be going to the closest appropriate facility is if you're transporting a patient a distance that you're going to be passing other hospitals or care centers that patient could be treated at, but they're going somewhere further for a higher level of care. The way to think of closeness in this aspect is if you're transporting a patient out of the hospital to a nursing home, just because there's a nursing home right beside the facility that you're at, but you're taking the patient a mile away, that still would be considered a close facility. Think of it like a radius. If people from that area leaving that hospital would normally go to that new facility, it's considered close. The only time they wouldn't be going to the closest appropriate is if they're transferring for some type of care that can't be gotten somewhere else. The next part, if it's a hospital to hospital, describe the services needed at the second facility, not at the first. This would be our higher level of care. What does that patient require that they can't receive where they're at? And then the last one here in this section, if it's a hospice patient, is the transport related to their terminal illness? Yes or no? The best way to think of this is, say you're taking a patient out of the hospital. Their hospice diagnosis is lung cancer. If they were in the hospital for some type of respiratory issue, it's pretty safe to say it was related to the terminal illness. If the patient was in the hospital for a hip fracture, it's pretty safe to say that was not related to their terminal illness. And then on the line beside it where it says describe, that is where we expect you to write what their actual hospice diagnosis is. So you could just write DX, whatever the hospice diagnosis is. Section 2. This is the middle portion of this form. This is to be filled out by whoever signs the form at the bottom. The first, number 1, is where they describe the medical condition at the time of transport that requires the patient to be transported by ambulance. They can fill out whatever they want in this part. They can put weakness, bed confined, non-ambulatory, altered mental status, whatever it may be that would support why that patient requires to go by ambulance. Number 2, they ask, is the patient bed confined as defined below? Yes or no? And it's the same exact definition that I gave you when we went over mobility. Number 3, they kind of double down. They say, can this patient safely be transported by a car or wheelchair van? May safely sit during transport without an attendant or monitoring? Yes or no? So they need to answer that. And then number 4 gives them a ton of selections where all they have to do is check the box that correlates with the patient. And it gives them a ton of reasons why that patient would require ambulance transport rather than going some other way. Section 3 is where they're going to sign. What we need in this section, we need a signature, a clear printed name with their credentials, and then we need them to mark the day that they sign the form. And at the bottom, we need them to check the credentials that correlate with their name. Now, a few things I have to mention on this. When I say a clear printed name, it needs to be clear enough that we can actually read what their name is, because sometimes we have to go out to the state of Florida website and actually pull the verification to show who this person is. So we need to be able to read their name. The other thing that sometimes is a little tricky, the date signed. As long as the date signed is filled out and the transport date at the top is correct, the date that they sign this form, it's okay if there's a couple days in between there, as long as it's prior to the transport. Now, the transport date in section 1 has to be correct for the day of transport, but this form can be signed prior to transport. The reason that this happens, say you have a social worker who might be getting paperwork together for a patient knowing that they're going to be discharged, but they don't know if they'll be there to fill out the paperwork. So they might sign this form and have it completely filled out, but have the transport date for the day that the patient actually is going. As long as it's within a couple days of the transport, no issue. Now, if you see that it was signed like a week prior or any more than that, I would question it. Also, if you're in section 2 looking at it and things don't line up with what the condition of the patient is, I would ask for another PCS form to be filled out. Now, the last thing I have to mention with PCSs, there are certain signer requirements. So the only people that can sign this form are a physician assistant, a nurse practitioner, clinical nurse specialist, registered nurse, LPN, social worker, case manager, or a discharge planner. They're all listed at the bottom of the form, so you don't have to remember every single one of them. The other thing I have to mention with PCSs, the reason that these are so important, there are insurance companies, including Medicare, who require that we have this on all of our non-emergency transports. So, if we don't obtain this form, there is a process we have to go through. We have to send a certified letter to the patient's primary care doctor. After the time of transport, the only person that can fill this form out is the primary care doctor. We send them a certified letter. We hope that they send a form back to us filled out and that it's filled out correctly. If they do not, we have to hold that insurance claim for 21 days before we're allowed to bill it, and we have to bill it letting them know that we did not obtain the correct paperwork. If you think about it, say there's 5 of these a day that we forget to get, or we get filled out, but it may be filled out incorrectly. At the end of the week, we have a whole stack of claims that we're not allowed to bill and that we have to hold for 21 days to bill them. It adds up just because of a piece of paper.
Remember, It's your responsibility to make sure that PCS is completed, name printed, and signed properly before you transport your patient.
Okay, last thing that we have to cover, signatures. This is in relation to the PCR, your care report. The first thing that I have to mention with signatures, always sign your own name. Never sign somebody else's name for them, even your partner. Make sure that they're signing their own name, you're signing your name. Even if somebody tells you to sign their name for them, say you get to the emergency room and the nurse is busy and she says, "Hey, just sign my name. This is it." Politely tell her that you're not allowed to do that she has to sign it herself. Signatures are all time stamped. This is something that we do sadly have to check. Please never sign somebody else's name for them. It is considered forgery. It is not good for your job with NHT. It is not good for your state license. We have had to go through that process with a crew member before. Please don't make us do that again. Now that we've covered that part, a signature and a printed name can either be a full name, such as Elisa Garcia, or it can be a first initial and a last name, A. Garcia. We are not allowed to accept a first name and a last initial, so Elisa G would not be acceptable. If a signature is not legible, document what that name is. So, for example, in the electronic reports, they have the spot where they sign. There is a box below it where they type in what their name is. If it happens to be a paper report and somebody signs it and then they print their name and it's not legible, ask them what their name is and write it in at the bottom of your narrative. PCR was signed by this person. Now, the thing that is so important with the signature on your care report, if you read all that fine print that's above it, that signature is actually authorizing us to bill the transport to the patient's insurance. If we do not obtain a proper signature, we have to send a certified letter to the patient. After the time of transport, the patient is the only one that's allowed to sign for it. If that patient decides not to send that back to us, we legally are not allowed to bill the call. So if we do not obtain a proper signature, we have actually ran a transport that we are not allowed to bill legally. I have a couple examples here. The one that's to the left-hand side, we see that we have a signature. This is an electronic report, so you can see where they typed in the name below. They typed in Carla R. If I were to go out to the state of Florida website, which covers all types of medical licenses, if I were to type in Carla R, I would probably have so many responses, I would never be able to figure out who it was that signed this report. As we see the one that goes the middle to the right-hand side, we do have a signature, but they have no printed name. Without that printed name, I'm unable to tell who that person is because it's not a clear signature. Also, it looks like it may possibly be a first name and a last initial, so I would never be able to verify who that was. So always get a clear printed name at least, so we are able to verify who it is that signs these reports. And that is all I got for you guys.
Sure.
Yes, sir.
Okay, if anything ever comes up, please don't be afraid to send a message in ESO, go to QA and ask them, hey, how do I take care of this? We're here to help you guys. We want you to write good, clean reports. That's all I got for you. Thank you very much.
Thank you.
Thank you.
Yep, have a good one.